of innovation, more than 7,000 patents issued, more than 20,000 employees globally working to help our customers to solve their challenges in everyday clinical practice. We are working to enable better, smarter, and safer healthcare to improve lives. One of the challenges in everyday dental practice is complexity of adhesive cementation. In today's webinar, our two outstanding speakers will discuss about that. Let me shortly introduce our speakers to you. Dr. Silvana Tering is an experienced specialist in prosthodontics. She is focusing on complex aesthetical and functional reconstructions of teeth and implants, using both traditional and digital methods, working mainly on minimally invasive technique. She is also lecturing and giving courses on a variety of topics related to full mouth adhesive restorative treatment on teeth and implant prosthodontics. Dr. Erwin Mecher is a chemist with over 20 years experience in the dental industry. He has contributed to numerous material and device developments and led the introduction on multiple innovations, including our Relix Universal Resin Cement. Following his passion for science, Erwin took on the scientific affairs lead for 3M Cement portfolio in 2021. In today's webinar, in the first part of it, Erwin will take us through the science behind the simplified adhesive cementation protocols. In the second part of this webinar, Dr. Silvana will guide you through various clinical situations illustrating the adhesive cementation steps using innovative products such as our incredible duo that can do it all. Navigating a webinar platform is easy. In the central frame, you will see the media presentation being projected. On the right side of your screen, you will be able to see summary information about our speakers. On the left side, you will find Q&A section, resources available for you to download, and the short survey about this webinar. Please share your impression afterwards. I'm sure you will have some questions. Please feel free to type your questions into the Q&A box, and please join us in a live Q&A session with our speakers to hear answers to your questions. We will have 2 live Q&A sessions. On November 4th, we will have a live Q&A session in German, and on November 6th, we will have our speakers answering your questions in English. Dear colleagues, I wish you a very interesting webinar and look forward to see you in a live Q&A this November. Enjoy!
Welcome to the Cementation Solved webinar, and thank you for taking the time for our training on cementation. Cementation is the key final step of the indirect restorative procedure, and it determines to a great extent the clinical success of the restorations you provide to your patients. Training on cementation is important because cementation became a complex task. In the past, there were mostly retentive metal-based restorations that could be placed with conventional cements. Today, non-retentive restorations that require more elaborate bonding protocols with resin cements are commonplace. The development of resin cements enabled the use of a wider range of aesthetic restorative materials, and this broader variety of materials adds to the complexity of cementation. Similar-looking materials require different pretreatment and priming protocols. Let's look at an aesthetic restoration like this one. It could be lithium disilicate, which would require HF etching and priming with the silane. It could also be a different type glass ceramic, a feldspathic glass ceramic, which requires the same primer, but a longer etching time. However, it could also be one of the highly translucent aesthetic zirconias. Here, etching has no effect, pretreatment with sandblasting is needed. For priming, a phosphate monomer such as MDP can be used, or for some cements, no priming is required at all. Finally, this could also be a resin-based or hybrid material, and here you have to look by brand if etching or sandblasting is the right pretreatment. So the dental material world got complex, and in a survey the University of Kiel conducted 2007 with German dentists asking on adhesive cementation protocols, only 7% knew the correct protocol for zirconia, which was a new material at that time, with a much better score for glass ceramics. The same group repeated the survey in 2019. 12 years later, zirconia was a commonly used material and the scores improved greatly. However, the scores for glass ceramics went down, with the most common mistake being that the zirconia pretreatment was now also applied to glass ceramics. So the steps of pretreatment and priming are important, and today we will focus on these two steps in this webinar, but we will also touch on other key topics around cements. Namely, we will start by looking at which cement to use and give some guidance on cement selection. Then we will dive into the topic of how to maximize your efficiency by minimizing the amount of materials you use. And finally, we will look at step-by-step workflows for zirconia and glass ceramic materials with a focus on restoration, pretreatment, cleaning, and priming. So let's start with part 1, when to use which cement. Cements have to get a lot of jobs done. They fill the gap between over 10 restorative materials and more than 7 substrates. No other profession deals with such a variety of materials and even biological tissues to cement, lute, bond together in an abundant variety of shapes. Hats off to all of you who master this task in your daily practice. To get the cementation jobs done, a broad range of cements evolved over time. They can be clustered in 5 cement classes. On the left side, you have the conventional cements, such as zinc phosphates and glass ionomers. On the right side, you have the self-adhesive and adhesive resin cements. Even so, all of these are called cements. They differ greatly in their chemical composition, as well as in their setting mechanisms and in their capability to form a bond to the tooth structure and the restorative materials. There is an overlap in indications covered by the different cement classes, and this makes it sometimes difficult to decide which cement is the best to solve the problem at hand. Resolving this question is a key goal of this part of the webinar. With over 50 years history in dental cements, we provide solutions for all cement classes, and actually 2 out of the 5 cement classes you've just seen were invented by Solventum and its predecessor companies. We introduced the first resin-modified glass ionomer cement in 1994, and with Relax Unicem, also the first self-adhesive resin cement in 2002. In 2020, we assumed a pioneering role in the latest universal resin cement innovations with the introduction of Relax Universal Resin Cement, and on this product we will touch on later in the webinar. Now let's simplify cement selection making for your daily needs. The basic selection principle for dental cements considers 2 variables: the retention resistance form of the preparation and the strength of the restorative material used. For a high-strength material on a retentive prep, any type of cement would work to provide the proper retention. Here, the decision whether to use a conventional cement or a resin cement is based on clinical covariables such as the aesthetic needs, the ability to gain access and apply proper isolation, as well as economic considerations. For all other combinations, resin cements have to be used in order to either compensate the lack of retention of the preparation or to stabilize the restoration in case of a low strength material. Now let's try to put this all together into a one-slide cement selection guide that aims to give you a recommendation how to reliably solve a cementation case with the minimum number of clinical procedure steps. On the top row you have the indications from left to right, starting with endodontic posts, crowns, bridges and partial restorations such as inlays and onlays, all the way to veneers. For the middle part, crown bridges, partial restorations, we have to distinguish between retentive and non-retentive situation. From top to bottom, you have the restorative material classes, going from zirconia and metals to glass ceramics and resin-based materials. This guide now gives you a cement recommendation for each material indication combination. In the upper left corner, for a strong material on a retentive prep, you can use a conventional or self-adhesive resin cement. In the bottom right corner, the recommendation is to use adhesive resin cements for non-retentive cases. As you can see, for some combinations, the guide gives two options to consider clinical covariables such as aesthetics, and this is described in the footnotes. The idea behind this less is more recommendations is that every eliminated procedure step minimizes the risk of errors and overtreatment and thus contributes to a better clinical outcome as well as time and finally cost savings. I hope you find this overview useful. What it definitely tells you at one glance is that you need multiple cements if you want to optimize the clinical procedure. And this brings us right to the next part, which is how to maximize efficiency in your cement portfolio. Resin cement drawers tend to be quite cluttered with materials. A market research has shown that 5 different resin cements and adhesives are used on average. This can cause confusion due to the different primers and adhesives needed for each cement, and this in turn will require more staff training. Using multiple resin cements in parallel also occupies more space, of course, and can add cost when a rarely used special cement expires and needs to be discarded. Here are 3 recommendations on how to maximize efficiency and finally contribute to more consistent results, time and cost savings. First, it is good to plan to use only one cement per category, so one conventional, one self-adhesive, one adhesive resin cement. And if you do veneers on a regular basis, you might also need a light cure adhesive resin cement. The second recommendation is to pay attention to the number of primers and adhesives needed to operate your adhesive resin cements. There are options that simplify this a lot by using more universal products. Thirdly, cements are used daily, so having an eye on ergonomics of the delivery, but also optimized consistency of the paste, and especially ease of use in terms of cleaning up excess cement is a very good idea. These recommendations are the guiding principle for the development of our cement portfolio. We recommend using one product like Ketaxen Plus for the conventional cementation, Unicem 2 for self-adhesive cases, and Relax Ultimate and Relax Veneer for adhesive cementation. All the priming and adhesive steps are covered by Scotch-Bond Universal Adhesive. This was our recommendation until 2020. 2020, we achieved the next level of simplification by unifying the self-adhesive and adhesive resin cement into one with the introduction of Relax Universal Resin Cement as a system together with Scotch-Bond Universal Plus Adhesive. This universal resin cement system makes the use of multiple dual-cure resin cements obsolete, further simplifying the cementation workflows. Now you have one solution for virtually all dual-cure resin cement indications. The new cement comes in a novel auto-mix syringe that minimizes waste and covers all self-adhesive indications. When combined with the universal primer and adhesive, the system also covers all adhesive resin cement indications. This means for typical cases where you would use a self-adhesive cement, you use Relax Universal without any further etching or priming steps. For the typical adhesive resin cement cases, you combine the cement with Scotch Bond Universal plus adhesive and appropriate etching protocols. With this system, it is now possible to go from a situation like this with multiple adhesive and self-adhesive resin cements and their corresponding restoration tooth primers and adhesives to this, which is a much more lean situation where you have all the cements combined into one and also all the primers and adhesives combined into one component, and also with a much smaller number of mixing tips required. In a one-year clinical follow-up with 30 evaluators, it was clear that using the Relax Universal Cement system has a positive impact on the economics and efficiency by reducing training time, the potential of mistakes, and the amount of expired product to be discarded. These workflow simplifications come with uncompromised clinical performance, as published in this 2-year retrospective clinical follow-up report. This concludes part 2 of the webinar, and we come to the final part, which is the step-by-step workflows, and here we will start with zirconia and metal restorations. The cementation workflow for zirconia and metal restoration starts with cleaning the prep and isolating as needed, followed by the try-in of the restoration. The first question to ask now is, was this already sandblasted before the try-in? If not, now it's time to sandblast. If the restoration was already sandblasted, contamination might have occurred at try-in, which requires an additional cleaning step. Second question to ask is whether the case requires adhesive bonding. Typically, zirconia metal restorations are regular crowns, so the answer is no, and a conventional or self-adhesive resin cement can be applied as explained in the cement selection guide. If the case does require adhesive bonding, for example in the case of a Maryland bridge, then priming with MDP is needed, etching and priming of the preparation, and the application of an adhesive resin cement. And now the actual cementation steps take place: seating of the restoration, cleaning up the excess, the cure, and the finish of the margins. For today, we will focus on this front end of the procedure and look at pre-treatment, cleaning, and priming steps. Pre-treatment for zirconia, alumina, metals, and most resin-based and hybrid materials is sandblasting, typically with aluminum oxide, grain size 30 to 50 micron at 2 bars pressure. In terms of workflows, the recommended workflow is to perform the sandblasting pre-treatment after the try-in. This way you get a fresh, clean, micro-retentive surface, ideal for bonding. In an alternative workflow, the sandblasting can be done before the try-in. Here you have to deal with the potential of contamination of the very susceptible pre-sandblasted surface at try-in. So you need to perform an additional cleaning step after the try-in to refurbish the bonding surface. Be aware that silicone residues cannot be removed by cleaning agents, so avoid using silicone-based fit disclosing materials at try-in if you don't intend to sandblast after the try-in. For cleaning of pre-sandblasted zirconia, different agents can be used. Here's a literature review on how to remove saliva contaminations. Phosphoric acid should not be used. It does remove contamination, but it also inhibits bonding. Water and alcohol are useful, but they don't offer the best cleaning result. What works really well is sodium hypochlorite and dedicated cleaning agents. In this study, the shear bond strength to zirconia before and after contamination was investigated for a self-adhesive resin cement. And what you can see is that saliva does deteriorate the bond strength significantly. It goes from almost 40 to close to 10 megapascals. Water can restore to some extent, but to get back to the full bond strength potential, a dedicated cleaning agent like Ivoclean or applying 5.4% sodium hypochlorite solution with a microburst followed by rinsing with water has to be performed. Coming to the priming step, the adhesion to zirconia works via phosphate functionalized monomers. The best known monomer of this type is 10-MDP, that is also included in Scotch Bond Universal Plus adhesive. The phosphate group of this monomer reacts with the surface of the zirconium oxide through a condensation reaction. In self-adhesive cements like Relax Universal and Relax Unisem, a different type phosphate functional monomer is used that forms a bond to the zirconia through the same reaction. And then the methacrylate groups, the double bonds of these monomers can copolymerize with the adhesive and resin cement monomers, this way creating a chemical bond between the zirconia surface and the resin cements and adhesives. Phosphate, like in phosphoric acid, also forms a strong bond to the zirconia surface and hinders the attachment of the phosphate functionalized adhesion monomers and should therefore not be used to clean zirconia as just explained. In this study, the bond strength of Relax Universal Resin Cement with and without priming with Scotch Bond Universal Plus was compared to other self-adhesive and adhesive resin cements. What you can see is that you get a very high bond strength to zirconia just by the cement on its own through the phosphate monomers included in the cement, and this can be further enhanced by applying Scotch Bond Universal Plus with the MDP primer. This concludes the step-by-step section on zirconia and metals, and we now come to the glass ceramics. The workflow for glass ceramic restorations also starts with cleaning the preparation and applying isolation, followed by the try-in. First question to ask is, again, was this restoration pre-treated by etching before the try-in? If this is not the case, then now it needs to be etched with hydrofluoric acid, followed by priming with a silane. If the restoration was already etched before the try-in, an additional cleaning step has to be performed. Second question to ask is if the case will require adhesive bonding. If it's, let's say, a typical crown, then this is not the case, so a self-adhesive resin cement can be applied. If the case does need adhesive bonding, for example, a non-retentive onlay, then etching and priming of the preparation followed by application of an adhesive resin cement, or in case of a veneer of a light cure adhesive resin cement is needed. And then we have the actual cementation steps: seating, cleanup of the excess cure, and finish. For this webinar, we will again look at this front part of the procedure: pre-treatment, cleaning, and priming. Pre-treatment for glass ceramics and also a few of the resin-based hybrid materials is etching with hydrofluoric acid. Here are typical etching times for the popular 5% hydrofluoric acid. You can see that it varies by the type of glass ceramic or hybrid material. The recommended workflow is to perform the etching step after the try-in to get a fresh, clean, micro-retentive surface, which is ideal for bonding. Alternatively, etching can be performed before the try-in, for example in the dental lab. Here at try-in there's a potential for contamination, and this requires an additional cleaning step to refurbish the bonding surface. And as said for the zirconia, also here be mindful to not use silicone-based fit disclosing materials if you don't intend to etch after try-in. In terms of suitable cleaning agents, water and alcohol have some effect, of course, but typically don't provide sufficient cleaning. What works well is phosphoric acid, which is now a bit confusing because we said you should not use it on zirconia, but on glass ceramic it's fine. And of course, cleaning agents also work perfectly. Coming to the priming step for glass ceramics, here the adhesion works different to zirconia and metals. We need a silane coupling agent. We have again a condensation reaction between the silica surface and the silane functionalized monomer, and the double bond in that monomer will now copolymerize with the adhesive or resin cement monomers. There are many different silanes available, everything from 2-bottle silanes you need to mix before application to pre-hydrolyzed classic silanes like Relax Ceramic Primer or Monobond S. Then there are a couple of universal primers that also include a silane component like Monobond Plus, and of course universal adhesives with a silane component like 3M Scotch-Bond Universal Plus adhesive. The silane formulation of this new version of Scotch-Bond Universal was improved, and as you can see in this study, it now reaches gold standard level silane bond strength. So comparing Scotch-Bond Universal Plus to a classic silane in a shear bond strength test to HF etched Emax cut lithium disilicate did not show a difference in bonding performance. This concludes the last section of the webinar. I would like to give you a short summary with key takeaways. We looked mostly at the pre-treatment, cleaning and priming steps of the cementation procedure. Pre-treatment should ideally be performed after the final try-in. For zirconia it's sandblasting, and for glass ceramics is HF etching as the pre-treatment. If the pre-treated surface gets contaminated at the try-in, then it's necessary to perform an additional cleaning step. For zirconia, sodium hypochlorite is an option. For glass ceramics, phosphoric acid, or for both, cleaning agents work well as well. In terms of priming, silanes are used for glass ceramics, and for adhesive indications, zirconia can be primed with a 10 MDP primer. With this, thank you very much for your attention. I hope you can keep it simple, whatever indication material combination you have to solve, and I hope you found this information useful. Thank you.
Hi everyone, thank you Guy Wille for the introduction, and also thank you for the invitation to hold this webinar. I hope I can add some value to what Erwin has already told you guys. In this presentation I would like to talk about some insights from a clinical standpoint on how to manage the sometimes difficult world of cementation. Of course, I would like to thank Solventium for sponsoring this webinar, but rest assured that the opinions, photos and videos in it are mine. As you may have already noticed, we live in a modern world where the patients demand aesthetics and teeth to look like teeth. That is why we have to level up our restorative and prosthetic dentistry. The question would be, is that so easy? Of course not. But is this possible? Of course, yes. The first step would be to have a mindset shift from this type of approach, of prosthetical approach, where the crowns were luted onto these prepared teeth, to this type of approach, where we need all ceramic materials and adhesive cementation in order to achieve a predictable and long-lasting result. This is nowadays possible due to improved protocols and techniques, and also due to improved materials that are available for each and every one of us. Another aspect is the fact that we live in a minimal invasive era where such deep preparations are not acceptable anymore. We again have to do the shift towards this type of preparations that are confined in enamel, and we all know that the enamel as dental substrate for bonding is perfect. So it doesn't matter if we talk about vital or non-vital teeth. As you may see on the left side of the screen, we have two teeth prepared for veneers, and on the right side of the screen, we have two non-vital teeth prepared for crowns. This type of approach has indication for all ceramic materials and adhesive cementation. And even if the time is limited today, I would like to approach the following aspects. Which cementations mode are available for us when using Relyx universal resin cement, how to efficiently condition zirconia and glass ceramics, how to use different modes of cementation, and we will wrap everything up with a case selection that will show you how to obtain the best bond not only from resin to ceramics but also from tooth to resin. You have already found out from Erwin that cements work, so we have to do our part and correctly condition these other two interfaces. If we were to do a classification on the cementation mode that we use nowadays, I would say they can be limited to this type of cementations, the self-adhesive one and the adhesive one. If we take first the self-adhesive mode, it's practically a cementation and it's required every time we have a retentive full crown prep and when we are not able to do perfect isolation with rubber dam. For example, this upper second molar, you may see the prep margins are very deep. It would be very difficult to ideally to perfectly isolate it with rubber dam. Additionally, it has no enamel on it and it's a non-vital tooth. So all the criteria show us that the decision would be to cement it in a self-adhesive mode. The second mode is the adhesive mode. It's practically a bonding that we do and we use it every time we have unretentive preps, where we know we need as much megapascals as possible. Every megapascal counts in this situation, but attention, we need a perfect rubber dam isolation. Let's have a deeper look inside the features of the Relyx universal resin cement. So it comes in this very efficient, I would say, syringe, and it has a very user-friendly and ergonomic tip. It comes in these 4 colors, and if we use it alone, it's practically a self-adhesive cement. The good news now is that when we associate this cement with the new Scotch-Bond Universal Plus adhesive, they make together an adhesive cement. So we can use these two products in an adhesive mode for adhesive cementation. This is a fully aligned system, we can say, because the bonding strengthens the bond and the cement cures the adhesive. So it's like a perfect marriage, I would say, between these two products. Let's have a deeper look into the universal adhesives also. They come in a very versatile one bottle. that is suitable for conditioning not only dental substrate but also materials like composites, silica ceramics, zirconia and metals, because they contain functional monomers like MDP and silane. They can be used in different etching strategies, as you see, but the best one, the most recommended, would be the selective etch strategy. Most manufacturers recommend 2 layers and intense rubbing and 5 seconds of air drying. Pay attention please to the silane contained in the universal adhesive. They are not stable in low pH solutions, and the application of a separate silane is beneficial for silica ceramics. So practically, this one bottle works on one hand as a tooth adhesive and replace these bottles on the first row, and on the other hand works as a restoration primer, replacing the bottles on the lower row. Let's see a little bit how we prepare these 2 types of materials. These are the most common we use in our practice. So we have the zirconia. The zirconia has to be sandblasted with aluminium oxide, clean with alcohol and dry with oil-free air. The glass ceramics, on the other hand, need to be etched with hydrofluoric acid, rinse with water for 15 seconds, and then dried with oil-free air. Here we have to apply the Scotch-Bond Universal Plus in the inner face of the surface for 20 seconds. So rub, 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 rub. I recommend a timer for this. Dry with oil-free air for 5 seconds. Maybe a more visual slide for the pre-treatment and cleaning of the zirconia would be this one, in which we have 2 main scenarios. The ideal one would be the first one, where we do the trying, and after the trying we completely condition the interface of the zirconia restoration. And I will start the video. You see I sandblasted it. If you feel like it, but this is not compulsory, you can wash and dry it. Then we wipe it with alcohol. And at the end we air dry it. And we do all these steps in the office after we did the drying. So like I said, this would be ideal. As an optional step, if you have, for example, non-retentive restorations like tabletops and you want to do an adhesive cementation, you could use the universal adhesive for 20 seconds, rubbing it, and air dry it for 5 seconds. In the second scenario, where we receive the restorations already sandblasted from the lab, we do the try-in. Here we have an extra step, pay attention. This requires a cleaning of the interface, and the easiest way to clean it is to use natrium hypochlorite 5.4% for 10 seconds. Of course, on the market there are other cleaning agents available, but this would be the easiest one. Then we have to do the next steps as in the classical protocol, so waterize and air dry. When we consider glass ceramics, the first step would be to hydrofluoric etch their surface. For lithium disilicate, the protocol is standard and very easy. We use a lower percent of hydrofluoric acid. It always has the color red, the 5% one, and we use it for 20 seconds. For the other type of glass ceramic, there is a possibility to use a higher percentage of hydrofluoric acid, like a 9% or a 10%, and we have to prolong the time that the acid remains on the surface. After this first step, you will see on the etched interface a chalky residue. This has to be cleaned because it will negatively impact your bone strength. And how do we clean these chalky residues? That is, so the first and easiest thing that you can do tomorrow in the practice is to use the classical 37% orthophosphoric acid, and apply it on this surface for 60 seconds. This will give you clean surface and it will create a clinically acceptable bonding surface. Of course, on the market there are many other cleaning agents available. You can use them. And if you really want to be thorough and have a perfectly clean surface, you can put the restorations in an ultrasonic bath for 3 to 5 minutes in alcohol. Good. After this clinical phase, we have to prime the restorations, and we use for it either a universal adhesive or a silane. And at the end, we will obtain a conditioned intaglio surface. Again, maybe a more visual example of the entire process. For example, here is a feldspathic veneer. You recognize it because I used a higher concentration hydrofluoric acid, the 9%. It has the color yellow. And in the second image, you may see the chalky residues, so the salts that are being cleaned with a special cleaning agent. And then the silane application and the final intaglio surface of the veneer. So the idea is, if we use the manufacturer recommendation from the Scotch-Bond Universal Plus adhesive, we will reduce the clinical steps needed to condition this type of restorations. So big advantage, I would say. Now let's see how do we choose in which way we use these two products. So like you've already heard, we have two modes, the self-adhesive one and the adhesive one. And of course we have some important questions to consider, but if I would have to come up with 4 criteria, they will be the following. So first of all, we see which type of retentive and resistance form we have. Do we have any friction? If we have this, we can easily think of a self-adhesive mode of cementing the restoration. Then we show if we have enamel on the prepared tooth. When there is a lot of enamel there, then of course we will choose to do an adhesive cementation. When we can isolate very good or perfectly with the rubber dam, then again we will choose an adhesive way of cementing the restorations. And as a final criteria would be the vitality of the teeth. This is not a decisive criteria, but for me, every time I have a vital tooth, I tend to choose the adhesive way of cementation, because in this way I will reduce my risk of postoperative sensitivity. So we have these 4 main criteria that help us decide. And I prepared here on the slide scholastic classification, if you would like, on the specific treatments that we can do and use the different modes of cementation. And let's start with the self-adhesive one. So the post and core reconstructions are always suitable for self-adhesive mode. I always prepare the canal space with natrium hypochlorite and distillated water and dry it. Then I adapt my fiber post to the channel and I clean it with alcohol. I apply the cementation, and here this cement has very nice tips that help you apply the cementation from the bottom of the canal, and you can very easily apply the cement in the canal with it. Then we light cure it for 20 seconds. Then we apply the bonding agent, in this case the universal adhesive, and we do the build-up. For the build-up, I like the bulk fill restorative material 3M. And then of course we do the preparation. And as you know, this type of situation requires a crown after it, and this crown will usually be again a candidate for self-adhesive cementation, and let's see why. So this type of prep usually has a very good friction form. This tooth has usually no enamel on it, or very little quantity of enamel on it. It's non-vital, and the isolation is sometimes difficult. So we choose without any problem the self-adhesive mode of cementation. We just have to pay attention and mechanically clean the tooth, rise it with water and gentle air blow it. Good. The next type of restoration would be the zirconia bridge. As you see here, the preparations have a good friction, so we have a good retentive and resistance form. When we have a look at the clinical situation, these teeth are non-vital. It would be very difficult to isolate with cofferdam, and we have no enamel on these teeth. So again, directly the decision is done, self-adhesive cementation. So let's have a quick view on the initial situation and on the final one in the lower row with an X-ray imaging and a clinical view after the treatments were done and the bridges were cemented. So like I've said before, the last criteria, the fact that the tooth is vital or not, is not necessarily a decisive criteria, because like you see in this case, I have one lateral incisor that is non-vital and the other one that is vital and has also a lot of enamel on it because it was minimally prepared. But even so we choose for this case to do a zirconia bridge and cement it in a self-adhesive mode. And as tip and trick, you can use always such Teflon band or Teflon tape to protect your pontics and to protect your neighboring teeth. In this way, you will need very little time to remove the excess cement after the final polymerization. And here is the situation with the glycerin strip in place for the final cementation, and this would be the final outcome immediately after cementation. So as you see, things work quite easily and nicely. Another situation where we choose self-adhesive mode is for cementing crowns and bridges on abutments, on implant abutments. It doesn't matter if they are metal or zirconia. We receive them with a very good friction because the dental laboratory prepares them in a perfect 6-degree taper. So they are not teeth, they are not vital, we have no enamel. So we have enough reasons to do the self-adhesive mode of cementation. But there are also situations where, for example, where we treat an entire arch or the full mouth, and in the cementation strategy, because we have to adhesively cement maybe some restorations on teeth, we do a complete isolation, rubber dam isolation of the arch, and we have between the teeth some implants. So we will not remove the gingival dams just to cement the crowns or the bridges on the implants. You can use the rubber dam and still have a self-adhesive cementation on these implants. And believe me, it is sometimes easier to place a rubber dam around such an abutment in comparison to isolating a deeply prepared tooth, for example. So that being said, let's go to the second category, and we'll talk about the situations where we cement in an adhesive mode and we will use the selective edge strategy. For example, here we have a second lower molar that had a direct restoration that failed, and you can see the deep margin of the destruction. This is the printed model of the distolingual destruction. We check the occlusion. Of course, the occlusion is not an ideal one, but let's be serious. In the clinical life, you may also know there are many situations where the occlusion is not ideal. So we choose to do an onlay out of lithium disilicate. We conditioned it accordingly, as you see. And then we went for the adhesive cementation. And let's see our criteria now. So we have the possibility to isolate with rubber dam. We have enamel in place. We have a vital tooth and no friction for the restoration. So we need as much megapascals as possible. So we do the dry try-in, then we sandblast, then we etch the enamel surface applying, this is where I applied the adhesive, and the restoration with the cement in place. This is immediately after removing the gingival, the rubber dam, and this is a recall at about 2 weeks after the cementation. You may see how nicely the gingiva responds to the ceramic piece. And we have also a control X-ray. For the moment, everything is nice and stable. Another indication for this type of approach is the overlay. Here we have absolutely no form of retention or resistance, so no friction. This is the preparation design. Immediately then the sealing was done at the preparation phase. You see I isolated with the rubber dam, then I sandblasted and etched the enamel surface. I applied a universal adhesive, and here is the clinical view after removing the excess cement and polymerizing and doing the final polymerization. After removing the rubber dam, of course, we checked always the occlusion, so this is the final result. Now we go on to this very interesting case in which the patient came to me with this situation. Please notice the two endodontically treated teeth in the upper jaw. This would be the clinical status. So his main complaint was a very, very high sensitivity on these 3 teeth. It was so high he couldn't eat, he couldn't drink, he couldn't brush his teeth. So it was really bad. He refused any complicated treatment. He just wanted to treat this problem. So you remember I had these 2 endodontically treated teeth in the upper jaw. So when hearing and seeing how badly his hypersensitivity was, I didn't want to prep these teeth, not even for 0.5 millimeter needed for occlusal veneers. So I gained my space from preparing the upper teeth, and the technician delivered these very thin occlusal feldspathic veneers. And as you see, they were conditioned accordingly. I used a higher concentration of hydrofluoric acid for a longer time, and then I did the rest of the steps. These are the clinical steps from the cementation phase. You see I have circled here the exposed dentin. Even if it doesn't look so dramatic, the sensitivity was there. Then I sandblasted everything. I etched only the enamel surface. I applied the adhesive and then the restoration with cement. And this would be the final outcome. And I did the cementation one by one for every of these 3 teeth. His sensibility was solved. He had no sensibility anymore, but as you may guess, this is not something that will last forever. So if he warned his enamel, he will do the same most probably also to these ceramic chips. But in the future, who will know? Maybe he will accept a more complex treatment plan. So we go on. The last category would be the one where we use the adhesive mode and the total edge strategy. And as you see, we can have clinically this situation where an endodontically treated tooth needs an overlay. We have enamel margins of the preparation, and we have a composite in the middle of the tooth. This is the ceramic piece, and it was out of lithium disilicate. It was conditioned accordingly. You see the lower percentage hydrofluoric acid for 20 seconds. The salts, the residues that are being cleaned with conventional 37% orthophosphoric acid, rinsed and air dried, and then we can apply either saline or universal adhesive. But attention, we never cure the universal adhesive that we put on the inner interface of the restoration. So let's see our criteria. Even if this tooth is not vital, it has a lot of enamel, it has no friction, and we could isolate it. So again, 3 out of 4 criteria that show us we can use the adhesive mode of cementation. Good. The conditioning of the interface, the classic 37% orthophosphoric acid for 15 seconds. We can do it because the acid will clean this composite surface. Applying of universal adhesive for 20 seconds, so rub, 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 set the timer if you need, and then at the end 5 seconds of air drying. Then we come with the prosthetic piece, which we fill with the resin cement and set it on the prep, remove the excess cement and polymerize. This is the final outcome. Another feature that I find great about this adhesive is that it's radio back, and this helps us in time to correctly make a diagnosis of some problems underneath the restoration. So the occlusion check, and be careful every time you touch the ceramic, you need to really thoroughly polish it. A classical example on when we use this type of approach, the total edge adhesive mode, are the veneers. And let's see why. So the friction is not there in this type of preparation. We have almost everywhere enamel usually. We can isolate them perfectly most of the time, and usually they are vital teeth. So they check every criteria on the list. So we do the dry trying. If everything matches our expectations, we do the etching of the surface, of the enamel surface. We protect our neighboring teeth with Teflon tape, and we apply the universal adhesive. This is the condition interior surface and the application of our cement. Then we come with the veneer and set it on the prep. Here you have two options. The first one that I do is to remove the excess cement with a brush before I polymerize. The second option would be to make a tack curing for 2-3 seconds, then remove this excess cement and then do the final polymerization. This is the final situation after polymerization and removing the excess cement. Good. Let's go on with the adhesive bridges. Like in this case, we have 3 wings on the canines and on the lateral incisor and 3 pontics. We do the isolation and we do the sandblasting and etching of the interfaces of the surfaces where we're going to do the cementation, the adhesive cementation. You see here we applied universal adhesive, and then we went on and polymerized everything with the glycerin strip in place. And this is the final outcome. Now, a little out of the box case, just to show you that you may be flexible, and if you know the ground rules, you can play with them. So, for example, here on this X-ray, you see 2 implants on the position of tooth 1-3 and of tooth 2-3. So these are 2 lithium disilicate crowns on the implants. These crowns need to be elongated for aesthetic and functional purposes. That is why and everything was great on the platform level, so the bone was there. I didn't want to remove these crowns to access the platform again. And I choose for it these 2 ceramic chips to modify the form and the length of these canines. I used sandblasting to remove the glaze on the crowns, and now I come with low percentage hydrofluoric acid, the 5%, and I applied on the lithium disilicate crowns for 20 seconds. Then I rinse everything off. And And I have no worries regarding the patient because everything is under rubber dam isolation. Everything is perfectly isolated, so there is no risk that this acid comes near to the patient's tissues. So again, the same procedure, the second implant crown. I rinse everything. And then I apply the universal adhesive, rubbing for 20 seconds, remember, and air drying for 5 seconds. I also use again the Teflon tape to protect the neighboring teeth. Then I set the ceramic chip in place. As I told you, I remove the excess cement with a brush before I do the pre-polymerization. And here is the pre-polymerization. Then I apply the glycerin strip, and I do the final polymerization. Even if we remove with brush the excess cement, it may be that we still have little spots of rest cement, and this curved blade, the number 12, it's a very efficient instrument in removing this little excess cement that may remain. Then I go on and do a finishing of the interface, either with arkansas or stones or with red coated instrument. And you will see at the end, I will come and polish everything. And depending on your polishing set, most of them have more granulations. I recommend to use what the manufacturer recommends. So if you have 3 different granulations, please use them accordingly to the instructions of the manufacturer. So mine has 3 granulations. I always start with the raw one and go to the fine one. And that helps me obtain a very smooth and nice result. So here's the final outcome after the cementation. And this is the last case, again an out-of-the-box situation. Why? Because normally for such teeth we don't need an adhesive cementation. First of all, because they have enough friction. Second, they don't have enamel. And third, they're not vital. But I choose for this case, for aesthetic reasons, feldspathic ceramics, and it was a case from second premolar to second premolar. And because I had to adhesively cement the rest of the teeth, I choose to do an adhesive cementation also for these 2 ones. I managed to have a perfect isolation with gingival dam. You see, I do the drying. Total edge strategy is favorable because you can also clean the composite with it. Then the application of the universal adhesive and the glycerin strip on the cervical part of the restoration, and the final aspect after cement excess removal. So these are the final restorations in place, and you see, if we do our job correctly, the integration of these ceramic materials into the soft tissues is perfect, and it looks so natural. And we come to our first one of our first slides when I told you that the patients look for teeth to look like natural teeth. Okay, this being said, I would like to make this recommendation to you to keep it as simple and smart as possible. I encourage you to make the most out of the materials available today and to trust the science behind them, because they really work. That being said, I would like to thank you for your attention, and I would like to invite you to stay connected. You have here a QR code for my Instagram, site where I post insights and tips from my daily work. I will close the presentation now. And I hope that my presentation has given you some kind of clarity in this big word of cementation. I'm looking forward for your questions. And again, thank you and bye-bye.